After penicillins, our next topic will be cephalosporin. These are also beta-lactam antibiotics, and we shall see the details. So cephalosporin, they are derived from Cephalosporin C. They are obtained from the fungus Cephalosporium acremonium. Cephalosporin nucleus consists of dihydrothiazine ring, which is fused with the beta-lactam ring, and just like if you have seen that for making semi-synthetic derivatives, we have had this 6 aminopenicillinic acid, 6 API. Here we have 7 aminocephalosporinic acid is a basic moiety to making semi-synthetic one. This is important. Then next is 7 aminocephalosporinic acids. It has been modified by addition of different side chains to create a whole family of cephalosporin antibiotics. These have been conventionally divided into 5 generations. These actually generations are depending on the basic activity they are having, just like we have got penicillin synthetic, semi-synthetic, and how penicillin got modified at the end. The cephalosporins are bactericidal. We have this mechanism, they are having same mechanism as it is there with the penicillin. They are inhibiting the cell wall synthesis. Again, mechanism is also same as a penicillin, only they bind to different proteins than those which are binding to penicillin. So they are binding with the penicillin binding protein 1 and penicillin binding protein 3, and thus there is a difference in spectrum potency, and there is a decrease in the resistance to this. Because of this only, because of their site of action is slightly different, therefore there is a action which is having, they have comparatively wider spectrum of action, they have a higher potency than penicillin, and they have comparatively lesser resistance than that of penicillin. So the action is what we call it as a mechanism, we call it as inhibition of transpeptidation. Because of that, the cell wall will not be perfect one, and because of that it will cause osmotic drive. Because of that there will be busting of that cell, there will be activation of autolysin enzymes, there will be lysis of bacteria, and the effect will be bactericidal in nature. Classification, they are based on antimicrobial spectrum, and as the spectrum increases, accordingly our generation that increases. On the basis of chronological sequence of development, they are divided into various generations. Example are the first generation, they were the very first one which were formed, and they were used in practice for many years. Then the newer generation came. Example of these are cephalexin, cephadroxil, cefazolin, cephalothin. Cephalothin is nowadays withdrawn. Then they exhibit good against activity against gram positive, but again they are good activity against gram positive bacteria, but modest activity against the gram negative organism. Most gram positive cocci like streptococci, pneumococci, methicillin sensitive staphylococcus aureus, they are susceptible to the first generation cephalosporin, but they have, the problem is they have modest activity against E. coli and Klebsiella pneumoniae and the Proteus mirabilis. So it has got comparatively less activity, and therefore they are failing into treating into this. So as it has been seen, same again we are comparing with penicillin. Penicillins were also having more activity towards gram positive like streptococci, pneumococci, and lesser activity against gram negative one. Second generation one are those which are having the cefaclor, then ceforanite, then cefuroxamine, acetyl cefuroxamine, then cipoprozil, cefamandole, cipoxitin, cipotitan. Out of that, last 3, that is cefamandole, cipoxitin, cipotitan, they are banned, and which are very commonly still available are cefaclor, cefuranite, ciproxamine, acetyl, and ciproxamine plain. Acetyl is given as the oral one. Basic salt is same. Then they are exhibiting increased activity, comparatively more activity than the first generation one, more gram negative activity. They have much less active than the third generation agents. They are less active against gram positive cocci and bacilli compared to the first generation drug. But again, nowadays their use has been declined because clinically better agents are available, like third generation and fourth generation. So up to second generation are now they are of little use. They are not much used nowadays. Then the third generation are cefotaxime, very popular actually, just few years back. That was called as a Taxim, very famous brand was there, cefotaxime. Then cefodoxime, ceftriaxone, ceftriaxone, cefdinir, then cefatazidine, cefibutane and cefoperazone. These are various cephalosporin, which are third generation agents. Out of that, most popular, as the name indicates, cefotaxime and cefopodoxime, they are cefotaxone. They are compared to these three are very popular into this. They are having highly augmented activity against gram-negative organism, but again similar to penicillins. That is, in case of penicillin, as we have seen earlier, that whenever it is the first one, the natural penicillin was having highest activity against gram positive. No other agent is as active as penicillin V in gram positive. Similarly, here also the first generation will have highest activity against gram positive, means their potency will be highest. But as you go for the next generations, their activity towards gram positive will be slightly decreasing, and their activity against gram negative will be highly increasing. They are highly resistant to beta-lactamase from gram-negative bacteria. Some are inhibiting Pseudomonas. Also, example is ceftazidime and cefoperazone, which is withdrawn because of the adverse effect. But these were active against Pseudomonas also. Some member of this group also having enhanced ability to cross blood-brain barrier. Example is cefotriaxone, and therefore they are useful in the treatment of the meningitis, which are called by pneumococci, meningococci, then Haemophilus influenza and susceptible other gram-negative rods. So they are useful. They are showing good activities because they are able to cross blood-brain barrier. The next are the fourth generation are there, that is cefpyrome, cefepime and cefazopram. These are the fourth generation. They are given. They can be given by intramuscular or intravenous route, and they are having highest activity or very good activity comparatively against gram-negative, gram-positive organism. So they are highly active against gram-negative. They are similar to third generation for gram-positive bacteria. That is comparatively having less activity than the first generation, but they are active. The fourth generation drug comparable to third generation, but more resistance to hydrolysis by beta-lactamase. So you need not to give any beta-lactamase inhibitors along with them. They are effective against bacterial infection, which are resistant to earlier drugs, like up to third generation. Even if there is a resistance to earlier one, here these will be active. They will be showing action. Then latest fifth generation agents, that is ceftobiprole and ceftaroline. These are two fifth generation agents. They are active against gram-positive cocci. Especially one of the very typical species is there, that is called as MRSA, that is methicillin resistant Staphylococcus aureus. This is MRSA is a very dangerous one. At many places it has been there. Otherwise, methicillin is one of the very good penicillin which can act against gram-positive drug, and it is having ability to destroy or means not get destroyed by penicillinase enzyme. It is inherently resistant to bacterial penicillinase or beta-lactamase. But there are some bacteria like some strains, some varieties of Staphylococcus aureus, that is methicillin resistance, and then that is very dangerous. In that cases, it is useful. This fifth generation are useful in that. They are also useful in the penicillin resistance. This Streptococcus pneumonia and enterococci, they are useful into it. Then resistance, what are the reasons for resistance? That is, they causes impermeability to the antibiotic to reach its site of action. There are alterations to the protein binding penicillin binding proteins, so antibiotic will bind with the low affinity and therefore it will not show any actions. There will be elaboration of beta lactamases that can hydrolyze beta lactam ring and inactivate them, the cephalosporin. So this is most prevalent mechanism, even though the latest one having lesser chances of getting resistance by this mechanism. Fourth, fifth generation have latest more comparatively resistance, more strength against these beta lactamase enzymes. Adverse reactions, that is, there is a pain after intramuscular injection. It causes thrombophlebitis, that is inflammation of the vessels or vein. It can cause diarrhea because of oral cephalosporin or cephalosporin. Cephalosporin is banned. So these are the major adverse effects. Otherwise, they are safe. Same as a penicillin, hypersensitivity, and but comparatively incidences are lower. It can cause hypersensitivity. Those which are allergic to penicillin, there are chances that they will be allergic to cephalosporin also. We call it as a cross hypersensitivity or cross reactivity, because they share same beta lactam structure, and therefore the adverse effects, particularly hypersensitivity, will be same. So sign symptom already we have seen, that is rashes, frequent anaphylactic, that is rashes, then anaphylaxis, angioedema, asthma, urticaria. This can occur. Cephalosporin, some of the cephalosporin which are potentially nephrotoxic in nature. Example is cephaloridin, which has withdrawn. Cephalothin is also withdrawn because of the acute tuberculosis necrosis. They cause serious bleeding. Some of these, example is cefoperazone and moxalactam. These are also banned because of these serious adverse effects. Then the other one are, there are some which are having interaction with the alcohol. As you must be aware, many people are having habits to take alcohol, and because of that they show disulfiram like action. If you remember central nervous system, in that we have seen disulfiram is the agent. It is also called as antabuse. This disulfiram will cause inhibition of alcohol metabolism, and because of alcohol metabolism there will be accumulation of acetaldehyde, and this acetaldehyde will cause severe nausea, vomiting, body ache, and many activities. So these are the drugs which will have disulfiram like action, like cefamandole, cifotitan, moxalactam, cefoperazone. Because people cannot leave their habit to have alcohol, and simultaneously this antibiotic treatment will affect the alcohol metabolism. Therapeutic uses, they are extensively used and therapeutically important antibiotics. They are effective therapeutic and prophylactic agents. They are very, very important in therapy, at least nowadays. If today's antibiotic use somebody will check, then they will find that the highest antibiotic use is with this cephalosporin, and one more class is there, that is we call them as fluoxacins. These two are highest used antibiotics nowadays. So first generation, where they are used, they are excellent for the skin and soft tissue infections. They are useful in the surgical prophylaxis. With the first generation drug are preferred for prophylaxis in procedures where skin flora is likely to be the pathogen, or because they maximally most of time there are gram positive bacteria, and therefore in that they can be used. Then second generation, they are displaced by third generation agents for gram negative infection, but they were earlier given in a treatment of this respiratory tract infections, but nowadays it is the augmentin, or that is amoxicillin is very popularly used, and in this. Then third generation, they are active against or they are used either with or without aminoglycosides, particularly severe gram-negative infections. They are caused by Klebsiella, Enterobacter, Proteus, then Providencia, Serratia, and Haemophilus species. In that cases, this third generation has found to be very active or very useful. Then ceftriaxone is a therapy of choice for the all forms of gonorrhea. It is very good agents. Uh, the dose is 250 milligram intravenous muscularly as a single dose. IV ceftriaxone is also used for enteric fever, or to what we call as a typhoid fever. Enteric fever is also that is caused by Salmonella type P, and this is found to be very good in that particular treatment. Cefotaxime, ceftriaxone are commonly used for community acquired pneumonia, and cefotaxime is a very popular drug for prophylaxis, particularly in before and after surgeries, and for the hospital related infections treatments. So cefotaxime is a very popular one, very popularly given in most of the hospital. It is one of the prime treatment it is given. Cefotaxime, cefotraxone are also used for initial treatment for meningitis because of their antimicrobial activity, good penetration to CSF, and there is a record of clinical success. They are drug of choice in meningitis due to Haemophilus influenza, sensitive Streptococcus pneumonia, Neisseria meningitis, gram-negative enterobacterias. These are useful. And ceftazidime plus aminoglycoside are used in combination against Pseudomonas meningitis. They are drug of choice in that particular. Then fourth generation agents, like they are similar to that of third generation agents. They are indicated for hospital acquired infection which are resistant to commonly used antibiotic. As I told you, so far cefotaxime was very popular, but after fourth generation, still for hospital acquired or for any surgical one, third generation cefotaxime and all these fourth generation are preferred. So these are various cephalosporin which are used. What are other beta-lactam antibiotics? We have seen earlier, if you remember, we have seen classes. These are carbamazepinums and monobactams. These are newer classes of beta-lactam antibiotics, and they are having similar actions. Then these are important therapeutic agents along with the beta-lactam structure. They are neither penicillins, they are not cephalosporin, but they are having beta-lactam structure. They have similar mechanism of action. They are also bactericidal, and by that virtue they are effective. Let us see next. They are example of this is monobactams. The drug in this is aztreonam. It is isolated from Chromobacterium violacum. It is only monobactam currently is in clinical use. It has got beta-lactam ring, but it lacks the thiazolidine ring. There is no thiazolidine ring, therefore we call it as a monobactam. It has got antimicrobial activity that differs from those of other beta-lactam antibiotics, and it is more closely resembles to that of aminoglycosides. Aminoglycoside means streptomycin, etc. Streptomycin, pramicetin, then all these type of agents are there. So in that neomycin, kanamycin, there are many such agents. So this aminoglycoside, what is their mechanism of action? If you remember, as a general talk we had, that is they are acting on the this ribosomal activation protein synthesis. So by this mechanism they are acting. They are primarily affecting the aerobic gram-negative microorganism. They can also act on gram-positive bacteria and anaerobic organism, but most of these are resistance. Only few are they are working on against it can be there. They are preferred for all sort of gram-negative infection in patient with renal impairment, where aminoglycosides are to be avoided, because aminoglycosides they are causing severe nephrotoxicity, and therefore they are not preferred in this streptomycin, etc. are not preferred in renal impairment. They are stable to most of the beta-lactamases which are elaborated by gram-negative bacteria. They can be given by intramuscular or intravenous use. Therapeutic concentration in the CSF, that is cerebrospinal fluid, in the presence of inflamed meninges uh, there. Particularly this case you can see with streptomycin also. Otherwise, streptomycin is impermeable or lesser chances of crossing blood-brain barrier. But they cross more if there is inflammation or there is a meningitis, that is inflammation of meninges. So that is rather a good sign. That means only if there is a meninges, then it will be crossing. Otherwise, there will be no chances and no adverse effect will be there. So here also same thing is there. That is the therapeutic concentration in CSF will be more in meninges, and therefore it is alternative to cephalosporin for therapy of meningitis caused by gram negative. Then other group is beta lactam antibiotic, that is carbapinums. They have broader spectrum of activity, that is more than most other beta lactams. They act against gram negative rods, they act against gram positive bacteria, and all and various anaerobes they are acting against. Example of these are imipenem, meropenem, and ertapenem. These are three penums belonging to carbapinum class, and as I told you, they are also beta lactam antibiotics. They are derived from compound which is produced by Streptomyces catalea. Mechanism is same as penicillin, that is binding to penicillin binding proteins and getting or affecting NAM and NAG, that is N-acetylmuramic acid and N-acetylglucosamine network. So because of that they are bactericidal. The advantage is they are resistant to hydrolysis by beta lactamase. They are marketed usually in combination with celastin, which inhibits the degradation of this imipenem by renal dipeptidase enzyme. This enzyme is present in the human kidney and it degrades it. Because of that the metabolism is faster of imipenem, and it is you need to give more doses. But if celastin is given, that will be inhibiting the metabolism of this imipenem, and thus the frequent dosing can be avoided. Without celastin, renal dihydropeptidase inactivate the drug, which result in the low urinary tract concentration. And if we give it, then it will be appearing in high renal combination. Adverse effects are nausea, vomiting. The important is seizures, that is epileptic like activities. Patient allergic to other beta lactam may also have may or may not, that means hypersensitivity reaction when given imipenem. Then another is drug in that class is meropenem. There is a therapeutic equivalence with imipenem. It is co-administered with celastin, that is not required. Meropenem is having less chances of seizure and therefore it is more safer in that matter compared to imipenem. And the newer analog into that is ertapenem. It differs from imipenem and meropenem because it has got larger serum half-life. So once a day can be possible, once a day dose will be sufficient enough. Co-administration with celastin is not required. It has got less seizure producing as compared to imipenem, and therefore it is better than this earlier one. All are parenterally given, but the problem is this intravenous or venous injection, intramuscular, is somewhat painful. Imipenem is given 6 hourly, meropenem is 8 hourly, and we have seen the last one is once a day. Okay, all are resistance to beta lactamase, all are bactericidal. Mechanism is same, that patients which are allergic to other bacteria may also have hypersensitivity when given imipenem or carbimipenem. Therapeutic uses, they are used because they have got very broad spectrum of activity, so they can be used against urinary tract infections. They are in respiratory tract infection like lower respiratory tract infection, then intra-abdominal and gynecological infections, skin, bone, joint, soft tissue infection, especially cephalosporin penicillin resistance and nosocomial bacteria. Nosocomial Anybody knows nosocomial what it is? Okay, write it down in group. Okay, so these are called as a nosocomial bacteria. They are effective against it. It is very important. And lastly, newer group of molecule is known as a carbacefin. Example of this is loracarbef. It is a synthetic beta-lactam antibiotics, so it is not a semi-synthetic or like that. It is similar to cefaclor, that is cephalosporin second generation. The antibacterial activity resembles to second generation cephalosporin, and it has been found to be quite effective in various conditions. So here we finish all penicillin and penicillin like agents, that is all beta-lactam antibiotics. These are all are bactericidal, as we have seen, and because of this bactericidal activity, they are used in practice. They are very good in practice, and they are one of the important resource or important regimen in the antibacterial. Yes, good, very good, Omkar. So they are the agents. So like that. So these are the hospital acquired infection. Usually they are difficult to treat because the patient which are coming, infected patient which are there, they are coming, and they do have some infections, and therefore there is a bacterial load is very high in that area. So because of that, there is a reduction in the immunity. The patient who going for some other problem, suppose somebody is going for maybe some gastric ulcer or something and being admitted, and the patient gets then other kind of infection. These are called as a nosocomial infections. Okay, so the person actually gets infection because of his admission or his reaching to hospital. So these are the nosocomial. So they are good one, as we have seen. So this is what various drugs which are available, and accordingly, as I told you, they are important drugs. Comparatively, they are more safer than many of the others. Whatsoever major adverse effects we have seen, these are the hypersensitivity and indirect activities. Those who were having higher toxicity, example, we have seen that some of the second generation, they were having nephrotoxicity and all. They are not used, or they are almost banned from the use, and those which are very effective, those are better, having lesser adverse effects, they are continuing in the practice. Only thing is, slowly resistance is formed, and still new and new antibiotics are coming. So antibiotics are, when I was studying, it was only second generation, and third generation was almost about to come. Now you have reached to almost fifth generation. So this is how the antibiotics, particularly those which are working well, having lesser adverse effects, their range is increasing. New and new drugs are coming into the market. So take care, be safe. Today this much is okay. We'll start with other drug, other type of agent in our next class. If you have difficulties, you can put in group.